Good evening, everyone. I want to welcome you to the February 28th edition of our Hospital CEO Forum, sponsored by the Greater Indianapolis branch of the NAACP and the Indianapolis Recorder. It is our pleasure on this last day of Black History Month to bring together a forum of the 4 CEOs of major hospital systems here in the city of Indianapolis and the state of Indiana. We are so honored to have them with us, and we are really excited to enter into this very important and informative discussion about the role of hospital systems and their relationship to health equity and racism here in the city of Indianapolis. I would like to welcome us to our event this evening, Ms. Crystal Ratcliffe, who is the president of the Greater Indianapolis branch of the NAACP.
Thank you very much, Joseph, and welcome to the critical discussion. Once again, my name is Crystal Ratcliffe. I'm the president of the Greater Indianapolis branch, NAACP. While we know health disparities have existed for African Americans for generations, the COVID-19 pandemic brought renewal focuses on just how much disparities affect not just our lives, but our quality of life. In a bold step to improve health outcomes for the Black community, the Indianapolis City County Council declared racism as a public health crisis. To that end, the CEOs of 4 local healthcare networks stepped up and made accommodations to not only address these disparities, but to eradicate them. In addition, recognizing the Recorder's legacy in affecting change for our community, as well as the Greater Indianapolis branch, President Robert Trugal and Crystal Ratcliffe, both legacy organizations, are known for advocating for their empowerment of the Black community to hold the virtual discussion with these CEOs to learn about their commitments and plans to eradicate disparities in healthcare. Tonight, 2 parts of that conversation. First, we will receive an update from the CEOs on where they are and their commitments to removing barriers and obstacles to the healthcare for African Americans. The Recorder is pleased this year to add new partner FYI to the discussion, as well as share a health equity reporter, Farah Yousry. Now we will begin our co-moderator with the discussion in part of the Recorder's change to the voice of the voiceless. And I'm grateful to our panelists for their commitment and their willingness to be held accountable. We also would like to thank Gary Holland, who has worked very hard from the NAACP to make this possible. Thank you.
Thank you, Ms. Ratcliffe.
Thank you, Crystal. I'd like to introduce myself. Hello, everyone. I'm Farah Yousry. I'm the health equity reporter with the local NPR station, WFYI, Side Effect Public Media, and the Indianapolis Recorder, and I'm your co-moderator for tonight.
And I'm Joseph Tucker Edmonds. I am an associate professor of Africana Studies and Religious Studies at IUPUI. I'm also honored to serve on the Education Committee of the NAACP. And I have been working with a number of our community partners to hold our hospital systems and our public institutions accountable for the statements that they've made and for the ways in which we can engage in robust and accountable conversations in forums like these. I wanted to just provide a quick history of this forum for folks who are joining us for the first time. Over a year ago, January 19th, 2021, 3 of the CEOs that are on the screen joined us, and we had a very robust and engaged conversation about the question of what does it mean for racism to be a public health crisis, right? That this is something that all of the CEOs had signed a document agreeing that this was an issue of concern and that they felt that their responsibilities as the leading healthcare providers in the state were to be able to respond to this and to specifically and with a great degree of nuance, respond to the concerns of the African American community and broader vulnerable and under-resourced populations in the state of Indiana. We had a fantastic conversation a year ago, and we decided at the end of that conversation that that was just the beginning, that we needed to maintain and develop this relationship. And that is what we've been doing over the last year. We have been meeting, we have been working together, we have been holding one another accountable. And today we're coming back to talk about the data that these health systems have collected, the ways in which they are seeing and imagining a way forward for our community, and also asking for them to name specifically the things that we can look out or look forward to as we move forward as a community and try to respond to and hopefully begin to resolve the inequitable care that certain portions of our population received. And so our hope is that this will be a conversation that will not end tonight, but that will continue in another 6 months or so. And we are very excited to bring them together, to have this conversation, and to continue to provide them an opportunity to report back to us and to be challenged and engaged by our audience and community members. And so for everyone that is out there in the social media world, we want you to know that we are listening and trying to hear from you right now. So if you type questions or comments into the Facebook chat or whichever media platform that you are using, we'll be able to have access to them, and we'll be coming back to those public and community questions at the end of our time tonight. And so I want to hand it over to Farah for the introduction of our CEOs and for the basic rules of engagement for this evening.
Thank you, Joseph. I'd like to thank our guests for tonight and introduce them in alphabetical order. Joining us tonight is Mr. Brian Mills, President and CEO of Community Health Network, Mr. Dennis Murphy, President and CEO of IU Health, Dr. Jim Callahan, President and CEO of Franciscan Health Central Indiana, and Dr. Lisa Harris, CEO of Eskenazi Health. Our forum tonight will include 2 rounds of questions. There will be a short presentation in the middle about a new data dashboard that the 4 hospitals are working on. We will conclude with renewed commitments, like Joseph mentioned, from hospital leaders and steps they will be taking in the short and long term for which we can hold them accountable next time we speak here in 6 months from now. Our community engagement team will be dropping links to resources in the chat box below. If you're tuned in via Facebook Live, you can always drop questions and comments down below during the show. And yeah, we'll be getting back to them. If we don't get back to them during this conversation, as a reporter, I cherish those questions so much, and I take them, to inform my own reporting and my colleagues at WFYI and the Indianapolis Recorder. So yeah, please feel free to do that. And with that, I'd like to begin our first round of opening questions. I would like to invite each CEO to take 2 minutes to answer, just so we can be mindful of our time to cover as much as possible. My first question would be directed at Mr. Brian Mills, and then I would invite each CEO to answer the same question. Looking back since our last forum, what would you say has been your most significant response, and how much resources have you put into doing that? We can't hear you.
It'd be a little bit better if I'm off mute, so. Hey, it's a pleasure to be here tonight. It's a pleasure to work with everybody here. And it's been a pleasure to engage with the NAACP and Indianapolis Recorder on an ongoing basis. Because we've got to listen and learn here. I feel like we're progressing. I think we've got a long ways to go. When you look at community, I've personally been at community 37 years now, last 13 as the CEO. And so I've experienced a lot of the things we're talking about. And I believe that our mission, which is to enhance the health and well-being of the communities we serve, is the right mission. But I also believe we put this emphasis in last year on embracing diversity in that, and ensuring equity and promoting inclusion. And that's really foundational in all parts of our organization. So we have we march by this pride values and the values that we have as an organization. We changed our I and our pride value to inclusivity, and we changed our D to diversity. That might seem like a little, not much for people. It's a big deal. And so therefore, everything that we're doing within our organization is focused around that. We had identified last year and hired our first Chief Diversity Officer, Diane McDaniel, fabulous addition to our organization. We promoted her. She is now a direct report to me. She sits at the highest leadership in our organization. She has access to anybody. She's established a committee within our board focused on DEI in all parts of our organization. I know this sounds like a lot of infrastructure, but if we don't have infrastructure, anything we do will not be sustained. In addition, we have looked at our board. And we've added 3 diverse new board members in the past year, which for a board of our size, that's a lot of change. And we've got more discussions on the way as we try to make sure that we resemble the communities that we serve. The other thing I would talk about is the amount of education we provided at all levels of our organization, that we've tried to make sure that everyone is understanding and have an open audience. They have the ability to talk to anyone here, have transparent conversations, and that as we go through as an organization, we also capture data and we can analyze that data. And I'll talk more about that later, some of the partnerships that we've put into place. But what I believe you would find out today that I wish I could have said a year ago or 5 years ago is that this is top of mind with anybody associated with our organization, from the highest part through our board, to our senior leadership, through the allocation of resources and making improvements in the communities we serve.
Thank you. Mr. Dennis Murphy, if you may walk us through some of the most significant responses you've been able to put together.
Sure. Thank you, Farah. And like Brian, I'm very happy to be here tonight. I actually think these forums are a really wonderful way to create accountability. And I think also to share knowledge. I think, Farah, the question was, what am I most proud of? I would say it's the breadth of our response over the past year. We've said that we have kind of 3 strategies that we'd like to improve as it relates to diversity, equity, and inclusion. The first is our culture. Over the past year, we've had just over 46,000 employees trained in multiple modules on either civility or cultural bias. So I know one of the questions you had asked is, what does that translate to? That's over $1.5 million of training and about 46,000 hours that our employees spent in training. I think, like Brian, a lot of organizational changes, either in terms of how we think about our mission. So a really clear, simple one was we said our vision was to make Indiana one of the healthiest states. We now always add for all as a very simple reminder to everyone. But we've also added a lot of infrastructure. So we had a diversity and inclusion office, but we actually created an office for health equity and recruited an incredible leader who will be speaking here later, but also expanded that diversity and inclusion office. We have some fairly major capital projects. So we actually added diversity leader within our design and construction office. And so there's about 8 people we've added and over $700,000 of salary and benefits every year. I think the thing I'm most proud of during this year, we changed our starting wage rate and now have a pathway for every employee to get to a living wage of $18 an hour within the first 2 years of their employment at IU Health. That didn't just impact new employees, that actually impacted everybody who was below $18 an hour. So it was over 11,000 of our 36,000 team members, and they were disproportionately skewed to women and people of color. So more than half in each category. That will be over $39 million annually, just that one decision that we will have made. And then our third category was around partnering with others on societal issues. And we made investments with the Center for Leadership Development as we think about education, Near North Development Corporation to help with workforce housing and affordable housing in our community. Also a pipeline program with Crispus Attucks, taking 30 to 35 high school age students and really mentoring them for 4 years and making a guarantee of a job offer when they graduate with IU Health. I met with the students and I said, I hope none of you actually take me up on that job offer because I'd like you to become doctors, nurses, go to college. But if you want a job right out of high school, we will provide that. And then finally, an investment in a Mosaic Center for learning and development along all ages. So this is really a community asset to help upscale and upskill people to better jobs. So maybe my breath, that's a set of highlights, but just the fact that we're moving in all three dimensions is really important.
Thank you. Dr. Jim Callahan, I know you weren't part of the first forum, but we're happy you're joining us tonight, taking part in establishing your commitment to fighting racism in healthcare. So on to you.
Yeah, thank you, Farah. Thank you to Joseph and Crystal. We are indeed really pleased to be here this year. This is our first year participating, and we're so pleased. So thank you. We recognize our role as well as a healthcare leader, one of the four here, mostly on the South Side, and looking forward to continuing our efforts in health equity in this partnership. We've learned from our fellow health system leaders as well as all of you in the meeting. For many years, we've sought to accomplish our mission of caring for everyone who comes through our doors, but going beyond that now, and we're a Catholic health system, and so we're called to build a just society with a special focus on those who are low-resourced and most vulnerable. So we're underway with 3 tracks of that. We seek to further implement community-based interventions. We seek to further develop a robust and diverse workforce. And we seek to further invest in our local and minority-owned businesses. So like our peers, we're invested heavily in serving the most vulnerable, mostly on the South Side, reducing barriers for health and wellness, providing care to those who are uninsured or underinsured, looking at and acting on the cultural barriers that challenge access to care, and improving the social determinants of health. Number 2, we seek to increase the voices that minority populations have in our organization. So in addition to increasing our minority employees and leaders, including additional African-American board members, we have established a community resilience coalition to identify gaps in the safety net and solutions to reduce those barriers to quality of life. And this year we're establishing a health equity council to focus on those issues. And third, we are really seeking to boost our engagement with minority and veteran-owned businesses. So right now, about 29% of the supplier businesses we use are verified XBE or minority or veteran-owned. So we're working with Valify and the Indianapolis Chamber of Commerce to increase this percentage further and total spending with such businesses. And by diversifying our spending, we think we'll build towards a more solid and stable community economy. So thanks.
Thank you. Dr. Lisa Harris? We can't hear you.
Let's unmute. Someone had to do it. I'm reflecting on when we started this and the impetus for this work and how we all felt that this was a moment in our community. And we also knowing that there had been many other moments, fearing that, the collective effort would eventually fade, with the pressures of, let's say a pandemic, which of course has brought to light even the bigger, to a greater emphasis of the work that we're focused on. But so I want to thank you. I want to thank the recorder. I want to thank the NAACP. I want to thank Joseph, Ms. Ratcliffe, everyone for keeping this alive, and for our partners across the community as we have worked to make sure that this is a time that we really reset the stage. And so, I don't think it's any mystery, as the public hospital and health system for Marion County, that we exist to promote equity and reduce disparities. And, we know that this work requires the entire community, and we've been at it for decades. But I know that this evening you want me to focus on what we've done in the last year, and you want to hear about dollars and data, and that's what I'm going to focus on. So I will just say that we started the process this past year of increasing our minimum wage, and by June 26th of this year, 814 employees and 521 employees of color will have been raised to $18 an hour. This represents a $2 million investment. We're also investing another $2.2 million annually in programs geared toward recruiting and retaining employees of color, including our Career Pathways program that prepares employees for higher wage opportunities. 77% of the individuals in this program are individuals of color. Our partnerships with HBCUs to provide paid internships across a multitude of disciplines, and our pharmacy residency scholars program. We've invested in annual implicit bias training for all of our employees, upstander training for our employees to become better allies for individuals experiencing racism. We've revised our annual performance appraisals for leaders to include goals related to equity and inclusion. This is how we hardwire it. We've focused on leadership training specifically geared toward recruiting and retaining a diverse employee base, and succession planning focused on diversity. Our senior leadership team now includes 33% individuals of color, nearing the distribution of our overall workforce at 40%. We understand that mental health is essential to physical health, and that access to healthful food, stable housing, good jobs, and healthcare and safe communities are essential to both. Our 12 primary care centers are located in the areas of greatest need, and in each, we're integrating medical care and mental health care and routinely screening for food insecurity, financial insecurity, and housing needs. This past year, we invested $2 million in developing a new department focused specifically on addressing these needs, and attracted another $3 million in partner investments. We also garnered $24 million in federal grants to further build capacity in primary care and mental health care, and double our community health worker workforce. Another $1 million from St. Margaret's Hospital Guild is enabling us to expand our collaboration with Community Health Network and the IU School of Social Work in growing the workforce of behavioral health professionals, knowing that issues of mental health fall disproportionately to persons of color. With record volumes of persons seeking primary and mental health care across our system, we're also investing $75 million in growing our physical capacity in 3 of our existing health centers and in a new health center on the east side. For 2021, $5.6 million, or 31% of our spend on this ongoing project, has gone to minority-owned businesses. And finally, encouraging others to invest in this work of promoting equity. This year, more than 80% of our community sponsorship budget, or $144,000, went to organizations who were able to demonstrate to us their commitment to diversity, equity, and inclusion. So again, I'm very happy for the opportunity to participate this evening, and for the work we have done together and the work we will continue to do in the interest of a healthier community for everyone living within Indianapolis. Thank you.
Thank you so much. I mean, these opening statements were fantastic, and I'm really excited because I know that our audience wants to dig in. And you all, I don't know if the CEOs remember from last year, but I like to kind of keep us moving and hopefully make sure that we're getting the kind of information that we want. And one of the things that I want to come back to, and we'll have a chance at the end to come back to this, is that we heard a lot of good interventions that some of the individual systems are doing. And our understanding is that you all are learning from each other, that you're not in competition, but that you are all working collaboratively to take best practices from one another and to deploy them in your own systems. And so hopefully as we get to the end of tonight's conversation, you all can talk about how some of those things that you all have been working on at your own units are now shaping and impacting what other folks are going to do. That would be really exciting to hear, around, a living wage that we've heard around, investment in training and things of that nature, and even in building units and buildings and practices on different sides or parts of our community. I want to move to our next question, though. One of the things, and Dennis, I'm going to come to you for this. One of the things that we talked about at our last forum and that we've been talking about all year long is, where is the data? Who's collecting the data? Who holds this data and things of that nature? And one of the things that the community said to us is that they wanted more data. They wanted to know how well you all were doing, and when you found out if you were not doing well, how you were going to respond to that data, either in order to correct and to redirect resources to those things. So I wanted to just ask you, Dennis, and then maybe someone else could jump in if they want to. You promised better data gathering as an explicit response to racism as a public health crisis. How has that been going, and how far along are you as IU Health in that area of moving the data gathering and data collection process forward?
Thanks, Joseph. I think I'll start with two levels. One is maybe you as a researcher know your outcomes are only as good as the data that goes in. And so maybe this is a plea for everybody on this call and webinar. There's something in this field of research called real data, which is race, ethnicity, and language. It's an acronym for that. And what we found in our own data when we started looking at it was a lot of people were afraid to tell us who they actually are. And so I think one really critical element of what we need as a community is actually to stress the importance of telling your healthcare providers who you are, because we won't be able to get to the core issues of equity in healthcare if you can't really understand who everyone is. We have, I think in some parts of our data, upwards of 35% of the people are unknown. And there are real issues. So I would tell you, in a very small community we serve in Frankfort, Indiana, there is a large Hispanic population. They are afraid to tell us who they are because they worry about their immigration status. And so we need to be a trusted place where people can tell us who they are so that we can care for them better. So the second half of that is, for the data we do have, what have we learned about ourselves? I think it's been really important for us, and I think it was Brian who said, how do you embed this in your daily systems? That we are now reporting all of our clinical effectiveness. So this is our outcomes data where we compare providers to one another. Our quality and safety data and our experience data all goes out in every format by gender, by race, and by ethnicity. And that includes to our board. That is not just overall data, but by specific clinical services. So our cancer outcomes, our cardiovascular outcomes, our neurosciences outcomes. So I'd like to say with the data we have that everybody gets equitable care, but that's not what we've seen. And you see disparities either in process metrics, and I know Dr. Tucker Edmonds later on is going to go through one example of that that we're trying to do as a community so that we can see how we do as Marion County. But I think it's in each of those areas shining a light on what we have as a baseline, where those areas of opportunity are, and then building in process metrics that actually change the outcomes in these things. And so I would say we're very early in this. We're learning what it takes to actually change the outcomes. I would tell you across the board in almost every metric, no race is where we'd like it. So even getting people to an equivalent set of outcomes doesn't mean as a community we have optimal outcomes. We need to get everybody equivalent and then move that entire average up to where we want it. And maybe the last piece I'd say, Joseph, is I think the one data flaw that's in this is we don't have good measures for those who don't access the healthcare system. And so I can tell you where we care for people, we know how we're doing, but when we don't, and maybe COVID is a really good example where in-hospital mortality, at least for most of us, is pretty comparable and equitable. But when you look at the overall outcomes in the state for COVID by race, they're very different. And the only thing our team can surmise is that means people aren't getting care. And so we really got to understand those access issues as well.
No, definitely. Thank you so much for that. I want to just to answer one quick follow-up. Dennis, you said that you're looking at clinical effectiveness, quality and safety data, and you said that you're reporting this to your board, right? Are there other groups, because tonight, we're standing here, for the NAACP and the recorder as a broad representative of the Black community. Are there other groups that you're making this data available to, and if not yet, is there a plan to make this data available so that we can all kind of hold each other accountable, know how your system is doing and how you're moving forward, given some of these data points that you're collecting?
Yeah, we haven't pushed it out further, and I think it's because of that big gap of unknown. And so maybe there's a bias or an assumption we have that those are underrepresented minorities largely in that pool. And so we believe that to be the case, but we actually want to prove that out, because I think until you get that to something maybe a little more manageable, you can have, I think, more definitive statements that you're making. But our plan, I think we've said all along, we want to be really transparent. I would love to be able to put that up on our diversity, equity, and inclusion page and say, if you're looking at a specific procedure or activity that you want to access at IU Health, here's our outcomes by gender, by race, by ethnicity. I think that's the goal.
And do you have a timeline for that or not yet? I don't want to push too hard, but I think people want to know, is this something that's in the next year or the next 5 years?
I would say somewhere between the two. If you were to ask me, I still think we've got a year's worth of work to get the data right going in. And then I think if I had my druthers, it would be 24 months or so. Because I just think it's going to take us some time to get the inputs right. And I just don't want to have a lot of skewed data out there.
Thank you so much. I don't know if I'm going to hand it over to Farah to move to the next question. I didn't know if anyone else wanted to respond to that, but you will have chances in your other responses to kind of circle back to what Dennis just alluded to and shared with us. Farah?
Yeah, I do have a follow-up for Dennis. There is a big gap in terms of the unknown. I understand even during my reporting, I see that popping up more than 30% unknown. So that really, it doesn't really help with informing, how can we improve health outcomes? So how are you collecting data? Are you changing the way maybe you're asking people to report? Are you doing any changes in this realm?
Yeah, we have undertaken a real education process with our very frontline registration staff on scripting. So I think some of this is you have to create an understanding of why are we asking the question at all? Because I do think we just ask the question, and if somebody says, I don't want to answer, we move on to the next question. I think it's actually taking the time to say, why is this important in your care? And why is it important long-term for the care of others? So that's got to get ingrained across a lot of people. And I think it's manageable though. That's why I'm an answer to Joseph's question. I think it'll take us some time, but it's not impossible. I don't see this as a 5-year issue.
Okay, yeah. So I'd like to direct my next question to Dr. Callahan. You spoke about improving diversity and representation in your hospitals. Can you talk about any changes to the hiring process? Like, how are you, of course, when we hire someone, you want to make sure they are qualified, but then you have to have like a big pool of applicants. And so have you done any changes to the hiring process to ensure you're on track to achieve those goals?
Sure. Yeah. Thank you, Farah, for that question. One thing we're doing is trying to go in to diverse communities and sponsor young people to get into the organization. So this year, we started a $1 million fund for scholarship and loan forgiveness targeting minority students across healthcare professions, nursing and others. And that's a big investment for us. And that's different, or in addition to the traditional training programs we've run otherwise in Franciscan. But I want to point out that Franciscan Health owns a construction company called Ton and Blank Construction, and it's based in Michigan City, Indiana, up in northern Indiana. And it runs a apprenticeship program in the building trades up there with good minority representation. So it is training seniors in high school or students who've recently graduated from high school to be electricians and carpenters and plumbers, which are in short supply and good paying jobs. And we're looking to move that program to Indianapolis next to boost the training of those folks also. So those are some of the things we're doing.
Yeah, and so with the loan forgiveness program you're talking about, can we have a number? How many students might this be maybe able to take advantage of this program?
Yeah, so that is gonna, we're starting out with 36 this year, and we'll seek to grow from there.
Yeah, Joseph.
I want to jump back to data, and I'm going to come to Brian for a minute, if that's okay. Brian, one of the things that you've shared with us is that you all have partnered with Health Catalyst to evaluate health disparities in your system, and so one of the things, and I think that, Lisa, you may have also referenced this in your document as well, right? That you all are also evaluating health disparities in your system. And we want to know, can you tell us what data you've collected? What have you found out thus far? How long have you been partnering with this organization or this program? And what data have you collected? And how is it shaping the way that you are delivering services, or what type of services you deliver to your patients?
Joseph, thanks for that question. And I'm really excited to share this with you. However, I don't think my response is going to give you the level of granular data that you're looking for this evening. But Health Catalyst is an amazing organization based out of Utah. It was founded by a group of clinicians from Intermountain Health who have, in my opinion, been in front of all of us for decades on this. They started a company. It's actually a publicly traded company. We do a partnership with them. What's really interesting is how this got started. How this got started on this question is that we introduced our chief diversity officer into the conversation regarding analytics. And somebody said, well, why do you do that? Well, go back to when COVID started. And we said, how good is our data? Are we discriminating? Is the data accurate? You look at diabetes, you look at sepsis, you go through all this, and it's one thing to count numbers, but to compare it against a baseline, how do you know that baseline is accurate? So interestingly, Health Catalyst, they hired a chief diversity officer and got him involved with Diane and our analytics team to start saying, and, oh, I should also say, if you go in, there's plenty of studies out there from insurance companies about how good is the data. You know, back to Dennis's comment, which is very, very accurate. We have a, don't know, unsure, unassigned in all of our demographics. That's not acceptable for what we're trying to do. But we're trying to make sure that the baselines, that the compare, what we're comparing ourselves to, are in fact valid. So therefore, we've said that we'll work with them and then also work with all of our other systems here and likely include the Indiana Health Information Exchange, because we've got a robust service there, and try to say, how do we go through and not just prove, oh, well, here's what the data says. Well, we need to make sure both what we're comparing each other to is accurate. And I wish I could tell you today, we know that it is. We don't. Mm-hmm. And so we need to go by with all the activity we're looking at, all the analysis we're doing, to try to make sure there's not disparity in the data as we're trying to make assessments on, are we treating all populations the same? And I for one, I'm concerned that we need to prove our data before we get too far ahead of ourselves and all of a sudden say, oh, everything's okay, or it's not as bad as we thought, or any of those things. I think that's what we want to be able to say, but we've got a lot of work to do that. The good thing is we do have data, and every one of the other systems here, we have data. There's organizations out there that can help us. And I can't wait to be able to report back to you and tell you what we found, what we learned, what changes we're making, and how we share that with everybody.
All right. What's your timeline? I mean, Brian, we got the audience listening, and we got folks that are interested because I'm with you. I'm a researcher, and I am a person that we want good data, but we also want to kind of have. I think we also have a community that's willing to take some things piecemeal in order to kind of help move this process and agenda forward. So when do you think you'll be sharing some of this data with the community?
Well, a few comments. One is that our data tomorrow is better than it is today. Okay. This is improving all the time. Mm-hmm. Secondarily, and I'll echo Dennis's statement, we must have education and standards of collecting data that are the same everywhere. And we need to really have conversations, not to put people in peril, not to put people's jobs or families on the line, but to make sure that if we're going to be providers of healthcare for our communities, we've got to have more information to do that. So that's the second one. The third one, I think what we're going to see is that when we report back in 6 months, whenever, we're going to identify some areas that we're going to have some data to show. We'll probably say it's still a bit raw, it's improving, it's better than what it is. And this cannot be, we can't sit here and just say, okay, we'll have our test completed in 2 years and we'll give it to you. That's not acceptable to any of us. We're working on this daily. We actually have people fully assigned to this. The cooperation amongst all the people here. I mean, I always say to our group, you look at community as an employer. We can make virtually 100% of those changes within our walls. You get into community as Community Health Network as a provider. We as a sole provider cannot change Central Indiana. We can't do it. We've got to lock arms. And fortunately, we've got relationships amongst ourselves that we trust each other in doing it. And that's what's important, is that nobody's taking this data and just hoarding it and said, we're going to do something with it. No, mm-hmm. This is something we're doing for the Central Indiana community, and then Health Catalyst can take it wherever the heck they want and help other people. But that's where we are.
All right.
Yeah, thank you. Dr. Harris, back to you. You referenced mental health in your opening statement, and it's definitely one area where the African American community continues to see huge disparities, made even worse by the pandemic. Since last time, what efforts have you put to address this? And has there been any measured successes, maybe where you were able to improve access or outcomes?
Well, thank you. And you're right. This is one of the things that concerns us the most, because all on a baseline of a huge burden of mental health in underserved communities, it's gotten worse. And there's no question the pandemic has taken a toll on the mental health of our community, and the burden has fallen disproportionately on the African American community. Just as we look at our data at the Sandra Eskenazi Mental Health Center, depression and anxiety have risen to our top 2 diagnoses by a wide margin. And we can see this with record-breaking volumes across our primary care and mental health sites, because of course, as goes mental health goes physical health. So this is really underpinning the surge in chronic disease we're seeing across all of our systems. The good thing is that this year we initiated a collaborative care model, which is the best practice for integrating primary care and mental health care. And so that greatly expands access, increases convenience, reduces the stigma of receiving mental health care. And in initiating this model, we recruited 2 new leaders, a physician champion, and a director of behavioral health and primary care, both of whom are persons of color. So recognizing that we really need to be sensitive to the particular challenges and concerns of those we're serving. In the spring of 2021, we also implemented an open access schedule for our outpatient mental health programs that again reduces barriers to care by eliminating wait times for new appointments. Again, just trying to make things easier. And we have seen an increase in the number of patients served of 7%. And that's just looking at our mental health volumes. However, we've seen a 33% increase in primary care, and we're delivering a lot of mental health care in the primary care setting now. And we are able to, because the services are co-located, we screen for these concerns, and we can get people referred into treatment immediately within that primary care center. So we've also, this increase in access, we've coupled this with outreach to the minority communities by, we're at Black Expo, for example, meeting with Black faith communities in order to make sure that individuals are familiar with our services and aware of how to access our services. And on the front end, similar to the approach we take to prevention in primary care, we're expanding our mental health, first aid, and mind-body stress and trauma management training to the community. We've been doing this within our own care, our workforce, and with our patients, but we're expanding it now into the community, including the faith-based community, public safety, criminal justice, and public schools across Marion County, again, trying to get out front and help people develop coping mechanisms in the face of the trauma, the acute and chronic onslaught of the trauma of the pandemic and the violence and everything else our community is racked with. Getting there in the moment and helping people learn ways to cope that reduces the turning to substance use. We've also, again, provided mental health first aid training to these very similar groups, the same array of groups, again, to increase awareness and reduce the stigma associated with seeking mental health treatment, so that everyone knows it's okay. You're not alone. There are things we can do to help. The biggest challenge, of course, to providing more care is the inadequacy of the overall mental health workforce, and that was before the increased demand that we're seeing for services now. And this is across the entire country. It's a national agenda. In that regard, we're hopeful about the promise of the partnership with a Community Health Network in our Behavioral Health Academy. This is a partnership both with community and with the IU School of Social Work, designed to add critically needed individuals to the workforce. And at this point, we've got 18 So we're working to garner additional funds and to grow that program, because it really does come down to workforce. I will say to that point, though, that the other effect of integrating primary care with mental health care in the sites of our federally qualified health center not only increases the convenience for patients, but it also improves reimbursement. And that's important because that drives resources that we can then devote to hiring more mental health professionals. So these are things that we've really just initiated. We've seen, a modest increase in access even this year, and we expect that will continue to grow.
Well, no, thank you so much for the response to that. I mean, these are so many critical issues, and I'm looking at and following the questions that are coming in from the audience, and we're gonna come back to that. And just to let you all know, because just to get you all ready for some follow-ups after our dashboard presentation, is that some folks are asking, when did you start to collect this data, and when, and how long has this been going on, so that we can have a sense of what is the timeline. Not only of when we'll get new data, but when you started to collect this data. The last question that we wanted to ask before we move into our quick break, and we're going to have a presentation on some of the dashboards that are going to be available, is that one of the biggest issues that we addressed during our conversation last time together was patient advocacy and patient protection procedures, right? So on one level, we talk about data and how we're collecting that and how we're looking at this from a macro level. On a day-to-day issue, though, there are patients that are telling us, or we're hearing from community members who are saying, I'm going into these hospitals and I'm having a less than ideal encounter with my provider, with the staff, with the system as a whole. And I want you to tell us about the status of these new patient advocacy roles that you talked about, Dennis, a little bit. What kind of data this person is collecting, when they started to collect it, if you know when that is, and what kind of real power does this person have within your organizational structure to actually affect change for an aggrieved party, one person who's complaining, but also the larger group of people who may be impacted by less than ideal policies. So I know that's a lot of questions there, but if you can answer some of them, that'd be great.
Yeah, and I think, Joseph, there's maybe two sides to this for us. So maybe the first side is the reactive side. So if somebody's having a bad experience, what happens? Right. And we have now throughout all our hospitals 24/7 patient liaison coverage where somebody will answer a patient directly, and if necessary, come into the hospital or be at the patient side, depending on the issue. The other side that we're instituting is this advocacy side that is more proactive. And what we're using for that, and then we are very early in this. So I would say our biggest rate limiter, and somebody talked about another issue, I think Lisa did, about finding behavioral health people, finding the right people to be patient advocates. This is not a generic job. You need somebody with good knowledge of healthcare, really strong people skills, and good problem solving skills. We've worked with Google to embed in our medical records a social vulnerability index. So this takes socioeconomic data, household composition and disability data, minority status and language data, and then housing type and transportation data, and basically creates a score based on your census tract from 1 to 0. And the higher the number, the more vulnerable you are. And our goal is actually to get our patient advocates to proactively visit and engage with everybody who has a social vulnerability index score above a certain number. And really the idea is that bar will be set fairly high initially until we get staffed. ideally, we'd like to see everybody with a social vulnerability index of 0.6. And what that means is you're 60% more vulnerable than the next, than the average person. So really trying to kind of titrate where we set that point. So I think we're trying to create two sets of structures for this, reactive, but ideally that function will diminish over time if we're good on the proactive side of actually, and so we have a goal of actually shifting people from one to the other, but we've got to build this first proactive side first. I think your second question was, what do you see? So over this past year, and maybe akin to probably what my counterparts are seeing, for last year, we had 6 months of fairly intense COVID experience. If you take January at the start of the year and then August through the end of the year, and that was a lot of COVID-related activity, either related to visitor restrictions or constraints. So people wanting to see more loved ones. We wanted more of them in there. We think it's good for patient care to have family members are advocates, just like our formal ones are. I think there are consistent themes around consistency of communication from the care team. So did I hear from the nurse the same thing I heard from the physician? And did I hear from physician A versus a consulting specialist the same plan of what's going on with my care? Those two themes were the most common. Maybe the third is really around responsiveness of care, meaning I do not feel like my tests are happening fast enough. The nurses aren't answering the call lights fast enough. So a lot around speed of care. So I think those create the core of what we're looking to address as we go through this. And I would say, maybe from my standpoint, I think the visitation issues and COVID-related issues are proximal. I think we can solve a lot of those just over time. We will revert back to older policies. The most important ones, I think, center around communication and consistency on care plans and diagnoses and what's next in terms of patient education. And that's probably where, once we get this advocacy function built out, I think the next tranche of work we have is how do we make sure patients are hearing the same thing from a broad group of providers who may be coming into their rooms.
Yeah. I know we got to go to our next, break, but I wanted to just ask one quick follow-up. Number one is the liaison. That's a phone number that a person could dial. Is that correct, Dennis? It's like if someone is looking for a patient liaison, that would be a phone number that someone could reach out to, and that's made easily accessible to all patients.
Every patient gets it on admission.
Okay.
They are on site and phone coverage after hours, but they're on call, so they have to come in if the issue is serious.
Okay. And then the next question is, are you doing anything to escalate if there is a patient advocacy request or patient liaison request that specifically highlights that they feel like the issue is racism or certain levels of discrimination? Is that advocacy concern escalated or sent to a particular team to address?
They're absolutely escalated. The typical escalation is if it's related to a physician, it goes to our chief medical officer. If it's related to any of our other clinical care staff, that goes to our chief nurse. Okay. And then that sort of starts a process with the patient in terms of an interview and understanding and sort of follow up afterwards in the investigation.
All right. That's very important, I think, for our audience. And I'm going to hand it back to Farah to move to our dashboard presentation.
Thank you, Joseph. Yeah, now I'd like to introduce Dr. Bronson Tucker Edmonds, VP Chief Health Equity Officer at IU Health and Associate Dean for Health Equity Research at IU School of Medicine. She will present on the data dashboard that the 4 hospital systems have been working on together. So yeah, Bronson.
Thank you so much. I'm gonna just get into presenter mode and hope that it cooperates. Can everyone see the title slide here? Excellent, thanks for the thumbs up, Dennis. Thank you for the introduction and just the opportunity. I'm not gonna take up too much of your time because I know everyone is really here to hear from the CEOs, but I did want to present some of the work that we were really asked as a deliverable that came out of the last town hall to begin to create community-facing opportunities to assess sort of the quality of the care that's being provided, particularly to communities of color. We developed a health equity analytics collaboration across the 4 hospital systems that are represented here. Actually, all 5 have been at the table at different points. We meet weekly at this point in time with sort of research, data, and DEI leaders from each of the organizations. And it's really an unprecedented collective effort to not only understand where we have opportunities to do more, but to begin to generate ideas and to share ideas about how we can do better. And so that's really where we're going from sort of data to action. In terms of kind of how we got here, we actually asked of our accountability partners here, the NAACP, the reporter, as well as some of the academic partners who are engaged, what they felt from the standpoint of the communities that they were serving really were some of the pressing issues. Because in the space of disparities, as I'm sure many folks in the community know, there are any number of areas of concern, and it's always sort of a challenging question of where do we begin this journey. And so our community partners suggested that diabetes, as well as infant mortality, and also mental health as the third case, but that those the first 2 areas of focus that they would wanted us to bring data and develop, in this case, a dashboard to begin to explore these issues was in the realm of diabetes. And that's actually a critically important area of disparities. We know that 1 in 6 African-American adults have diabetes, and that's compared to kind of 1 in 10 when we look at the white population. And then in the space of control, in terms of whether or not their diabetes is adequately controlled, and we also see similar disparities with only 24%. I'm sorry, with 24% of African Americans having diabetes that is uncontrolled, and 29% in our Hispanic and Latinx communities. And that means that that basically means that 3 times the rate of uncontrolled diabetes when we're looking at our Hispanic populations as compared to our white populations. So this is a critically important area, and we thought it was a fantastic space to sort of start this endeavor of presenting the data and sharing greater transparency and accountability around our performance. Before sort of moving to the data, and I will get there very shortly, I do just want to frame this conversation to understand, I mean, you all have heard from the CEOs this evening, a number of endeavors that they're, and ways that the organizations are trying to really partner and thinking about socioeconomic factors, thinking about the built environment. It's critical to kind of acknowledge upfront that we as healthcare institutions can't eliminate health inequities alone, that we have to do it in partnership. And that's because 80% of what really determines our health outcomes and drives a lot of these health inequities is really happening outside of our 4 walls. I usually say 20% is happening inside of our 4 walls and 80% is happening outside of our 4 walls, which means that we've got structural inequities, we've got structural racism, we have a host of structural and social inputs that are disadvantaging community members before they even hit the door. And so that doesn't mean that that gets the healthcare system off the hook. In fact, we have to be held accountable for our contributions, and that's what we're here to discuss this evening. But it does mean that we have to do this work in partnership across other sectors. And so we wanted to just shine a light on where we think that we have sort of a critical contribution to be made in the space of reducing health inequities. First of all, some of the conversations that's been had about increasing workforce and leadership diversity. We have the opportunity to implement interventions into clinical care that address disparities. Not the least of which actually is addressing issues of bias, addressing training for cultural competence, addressing those issues that contribute to suboptimal patient experience in our health systems, as has been discussed. We have opportunities for greater community engagement and for partnership, not only with communities, but also across sectors of government, housing, education. And again, some of those things have been talked about this evening. But what I'll just spend the next three slides just reviewing is really in this space of identifying disparities and then improving outcomes by virtue of collecting data, like we talked about those real data efforts, monitoring that data, so looking to see and being held accountable for how we're making progress, and then creating greater transparency and finding ways to share and disseminate those data with community members. So that's the spirit of what gave rise to this discussion about creating community-facing dashboards. And we opted to do so collectively, in part because we serve this community collectively. You'll see here that the way that we pulled this population together is that we, in terms of the population that's represented in the dashboards, is that we selected Marion County residents who have a diabetes diagnosis and have been treated within any one of our 5 health systems during 2019 and 2020. And in fact, when you start to work with the data, you recognize that people are not necessarily getting all of their care in one place, and that we actually are caring for this community collectively. What this data source does is, what this slide is intended to do is just to kind of orient you to the fact that if you look at the Marion County population makeup overall, and then you look at the population of diabetic patients that are being cared for in our hospital systems, that you are seeing that disparity, that disproportionate portion of the diabetes patients are African American, whereas 20% of the Marion County population is made up of African Americans. You're seeing in our diabetes population in our 5 hospital systems that 37% of those patients are African American. So with this slide, just to kind of orient you, is really trying to depict, we decided that it was really important to monitor those aspects of care that we can be held accountable for. So we looked at best practices. What are the labs and the care that we should be providing for every patient who comes into our 4 walls, right? Every patient should have these tests being done at least annually in order to monitor their disease progression and disease severity. And so when you look at the overall when you're looking across the board, you can see that we have some work to do, because ideally this would be, in a perfect world, 100% for every group. And we are, there's room to grow across the board. But then when you look within sort of these bars, these gray bars, you start to see that if we're talking about tests of sort of blood sugar control and obesity, blood pressure, these are kidney function tests, you start to see that there are some noteworthy differences with regards to how African Americans and Hispanic patients are sort of being assessed with regards to their diabetes control. While they are more likely to be assessed for obesity and high blood pressure, they're actually less likely to have their hemoglobin A1C tested, which is a measure of how their blood sugar has been controlled over the last 3 months. And we also see some differences across the bottom in terms of microalbumin, which is a test that looks at early signs of kidney failure. And this is a slide that really then says, well, how well are we controlling their blood sugar and sort of controlling their blood pressure and these different sort of measures of disease severity. And again, and Dennis alluded to this earlier, we have work to do across the board. We don't have any superstars here with our efforts coming in sort of 55 to 62% in terms of overall rates of control. But as we look at these tests, you do see areas of opportunity whereby we've got sort of gaps, about a 6% gap when we look at African American control as we compare compare it to the rates of control for our white population, and actually a 20% gap, 24% actually, with regards to our Hispanic or Latinx populations that we're caring for. Likewise, some gaps with regards to cholesterol control and blood pressure control as well. So this is really just a starting point for this conversation. We recognize that data are not sufficient. They're actually, we believe, necessary to help to point us to where we have opportunities to improve and where performance improvement efforts are going to be needed and required. But this is really, again, intended to shine a light on where the gaps are so that we can begin to be called to collective action in terms of closing them. And the other piece of why we wanted to do this work, and I know what our community partners have really been asking about, is how also do we provide a call to action for you in the community? What is the opportunity for you all to be engaged? And so that's another reason why we developed these dashboards, because now you have these tests that you can sort of go in and ask your providers whether or not they've been checked, they've been tested. You should be able to go to this dashboard once they are available to be disseminated. And we're going to work with the recorder to figure out how to disseminate that, as well as this sort of resource. And because part of this effort is not just about having data for the sake of data, but how can we actually inform you as community members and help you to be more engaged and activated and prepared to be able to have the important and tough conversations with the doctors and other practitioners who are providing you care. So these resources will be available. We're going to work with our partners to get them out to the community. But that's where I'll stop and sort of hand the microphone back to the folks you really came to hear.
Thank you so much, Dr. Thank you, Dr. Bronson. Valuable information. We will move to our second round of questions. We'll try to keep answers as short as 3 minutes if possible, in order to be able to, go to our final round of questions and to look forward to what's to come next. I'd like to start with Ashkenazi, Dr. Lisa Harris. We know from studies that there are patients who experience persisting symptoms that could be debilitating at times after they get a COVID infection, long COVID, they call it. And that's becoming an increasing concern with the significant rates of infections. It's projected that would be, there would be a big number of COVID long haulers. Do you have a plan to address long COVID, especially for underserved communities who typically are less likely to seek care, even without COVID and the pandemic and all of the barriers that are there?
Well, thank you so much for that question. We are also deeply concerned about the impact of long COVID on our community. And we know that it affects many organ systems and most importantly, the whole person. And so for this reason, providers from our primary care network met virtually with our specialists from the disciplines of psychiatry, physical medicine, rehabilitation, cardiology, neurology, pulmonary medicine, to learn more about the care of patients with long COVID symptoms. And this is getting to your point too, that patients have greater access to primary care, and we have more of an opportunity there if we're alert to some of these conditions. So this group pulled together the latest knowledge about long COVID, including the long-term effects, and also the evidence-based recommendations for diagnostic evaluations to ensure that other problems masquerading as COVID weren't missed. That's one of the things that can happen when you're in the middle of, you're thinking everything's, COVID. Well, there are a lot of other problems that are besieging individuals as well. We want to make sure we don't miss them and just assume everything is COVID or long COVID. So the group developed. I love that you asked about a plan. I think it's important to be specific. And they agreed that these symptoms would be evaluated, managed first in primary care with, co-management with specialists if necessary. But if the symptoms persisted more than 3 to 6 months, then they would be referred to the appropriate specialty clinics. And that, again, is using our more precious resource of specialty care to best advantage. Our patients who are recovering from severe COVID, having had ICU stays, are being managed in our post-critical care outpatient clinic that we established years ago specifically to address the sequelae of critical illness. And this is a particular interest to our physicians and our researchers at Eskenazi Health. And to your point, 37% of the COVID survivors we're seeing in this clinic are African American and 35% Latinx. So you're exactly right that this is work we need to be doing as in terms of our focus on vulnerable populations. But I want to just add something else, because I think at least as important as the impact of long COVID is the general impact of mental and physical health on mental and physical health of the pandemic. And this impact has fallen, no question, disproportionately to communities of color who already bear the biggest burden of chronic disease. And we saw this during and between the pandemic surges. During the first surge, as the only health system that's focused solely on caring for patients in Marion County, we cared for 23% of Marion County residents who were hospitalized, even though we only represent 9% of the hospital beds in the county. And 39% of those patients hospitalized at Eskenazi were African American and 42% Latinx. And so we've remained over 90% full for the past 2 years, even between the COVID surges. And we've been at over 100% capacity for most of the past several months. And this is at the same time that we are delaying care for individuals who need elective surgeries and procedures because we need the beds for acutely ill patients. So, we're seeing record volumes of patients this year across our entire health system, including primary care, specialty care, mental health, and in the hospital. And so a big focus now is on assessing opportunities for expanding capacity for both outpatient and inpatient services. So long COVID is no question that's something we need to be worried about. I think even a bigger problem is just the hit to mental and physical health that the pandemic has taken across and resulting in even a greater burden of chronic disease and patients filling all of our hospitals.
Yeah. Dr. Callahan, if you want to chime in about your efforts to,
Yeah, certainly commend Dr. Harris and the Eskenazi team and what they've been doing. And certainly long COVID is a difficult problem. And, for our audience, it can be fatigue and shortness of breath, but it can be a brain fog and anxiety and depression and pain. So it's very difficult. We start with a primary care approach as well, but in the field of rehab or physical medicine and rehab, we've actually established a clinic consistent with one of the 80 in the country that have a rehabilitation approach to this. And so we've treated over 500 patients in it. So it takes a rehabilitation focused approach led by one of these physical medicine and rehab physicians, working with pulmonary doctors and occupational therapy and psychology and so on to improve those folks' function who have that. We've treated patients of diverse backgrounds, and we're working with our system hospitals around the state to try to ensure that their diverse communities have access to this service too. And certainly, again, want to echo Dr. Harris' comments on the behavioral health effects that the COVID pandemic has had.
So is that some sort of like long COVID clinic?
It is.
Okay. And so how are you trying to, spread the word somehow? How can you access that if you have...
So if anyone would want to, they could contact our Franciscan Physician Network neuroscience specialists, and we could get a timely appointment for them.
Thank you.
I want to jump in, and one of the things that I want to get to, and this goes back to, I think, Dr. Harris and Dennis, I want to come to you all because this was kind of reported earlier last week, I think, about hospitals being penalized by the Center for Medicaid and Medicare Services because of problematic services or things that might have gone wrong, or the number of cases of sepsis and things of that nature, or accidental mishaps that were happening. And the reason we want to ask that question is, first of all, we want you to explain to our audience why you're being penalized. And I think that Eskenazi has been penalized for the last 6 years, maybe 6 or 7 years. And I think eight. And IU Health was just penalized this last year, I think, in this thing. What is this about, right? Reporting has been done on this, but the other reason why we're asking this question is not to say it's for you to spend a lot of time on this issue, but we want to understand how you are promising to be transparent when things like this come up, right? When there are things that go wrong, or there are things that are not the way that you want them to, the outcomes that you had desired. How are you planning and promising to report that to our community and to the community partners that you say you are going to be accountable to? So Dr. Harris, we can start with you, or Dennis, but let's start with Dr. Harris and then we'll move to Dennis.
I'm happy to start with that. And as you know, these data from the Center for Medicare Services are publicly reported. So the data is out there, and we support this transparency. Public hospitals as a whole were among the first to start really, advocating for transparency. And these are data that we are working to provide internally, both to our employees and also to our patients. And so we're working on internal dashboards that will be shared that way, that will be shared in addition to, again, this data being widely publicly available. So I think that's well known, but what is less well known is that hospitals such as IU Health, all of us on the call, Eskenazi, are rated across many different measures and by many different organizations, not only Medicare. And it makes it difficult to draw conclusive comparisons. I mean, we could talk about one, being a 5-star CMS hospital in the same period where we were getting, we made the list for the hospital-acquired conditions. That's kind of why we don't go out and tout that, because we recognize that the whole picture is much more complicated than that. And so we don't think that it's necessarily correct to go and just latch onto the good data point when there are multiple surveys that are out there. And the CMS rating system, though, which we fully support, receives a lot of attention because it carries financial penalties for lower performance. So that's why this is one that I think is almost always pointed to when the information comes out. And on some of these measures, we actually consistently score better than our peers. One of these measures is in our low rates of rehospitalization. CMS actually assesses a higher penalty, financial penalty for that measure. But as you said, we're focused here on the hospital-acquired conditions. And I will just say that we have invested considerable resources to improve in this area, despite the limitations of the measure, as both reported by the IBJ and Kaiser Health News nationally. The single biggest criticism being that the rating doesn't take into account the struggles of poverty, the social determinants of health that we've been talking about, that are faced by our patients, as well as the overall clinical complexity. But to address these hospital-acquired conditions, we redesigned our quality department 2 years ago, focused several rapid improvement events on specifically on these hospital-acquired infections. And over the past 2 years, our scores have consistently improved. But because the scores of everyone is improving, we are still just above the threshold set by CMS. And so we are, getting to the point where it could be even just one event that separates us from being on the list or off the list. And it's going to be a couple of years probably before we start to see the improvements, because these data are, of course, several years in arrears. But just know that we hold ourselves accountable to competing with the best on quality. We, safety net health systems across the country will talk about how the issues we've raised about the challenges of caring for individuals who, again, they just the effects of poverty, and what that the extra challenges that presents. But these are the folks we've signed up to serve. These are our patients, and so we absolutely hold ourselves accountable to achieving the same quality outcomes as anyone would expect anywhere. And again, even on several measures, even within this 8-year reporting period, we ranked the highest among the hospitals. So we don't go out and toot our horn on those, because we know again that the whole the picture is much more complicated.
Yeah, thank you, Dr. Harris. Brian, I'd like to ask you this question, but it's not directed just at you. It's an issue with all of the hospital systems here. But I'd like to get your input. One of the biggest barriers to seeking medical care for many in the African American and Latinx community is cost of healthcare. According to reports, your hospital systems charge Hoosiers well above the national average. In fact, Indiana is among the states with the highest healthcare costs in the nation. If we want to foster health equity, access to care is really at the core of that. So what kind of steps have you taken to address that?
Well, a few things. I'll start out with saying I don't agree with the RAND study. So I realize that's what you're quoting. I don't want to get on a tangent here. Be more than happy to spend time to go through all the other studies that are out there that interpret this differently. But so that's not an argument, just a statement. But access is critical to everything we do. I know it's the same with our peers. We at least have the ability now to monitor access by location, by doctor, by diagnosis, from a primary care to a specialty care. We have goals. Every part of our system. People define access differently. I mean, we at least have the ability now, whether it's virtual. Some people would say that's not access. We believe it's a form of access. We have shared medical records that allow us to have patients seen with better data than they've had in the past, even their own data that they're seeing at the same time. But when it's all said and done, the other thing that we're doing, to your specific point, is that we have teams of people that literally help patients find insurance or support or services that allow them to make sure that they know what they're eligible for, and we get them signed up. We enroll them. And to me, that in and of itself is one of the best things that we do, is to make sure that people can access programs. And it's a very complicated system, and that we can make sure that they get all the benefits that they can receive, and then with that, and whether it's other types of policies support them with their non-healthcare issues. So we have automatic online programs that we connect them with for transportation, or for medicines, or for food, or housing, and that's when because when you go back to the comment a minute ago about the picture about healthcare, we're still responsible for it. We're dealing with about 20% of it. So we've got to have connectivity to the other 80% in order to make a difference. And I know my peers on this call do still have similar programs. And I just really think that as we go into this overall cost of care, people are looking at what it costs to them. And that's really what anybody, regardless of who they are.
Talking about value versus cost.
Yes.
Value of care you're trying.
Absolutely.
Yeah, I mean, there is a letter, though, from lawmakers asking hospital systems in Indiana to take steps to address that. I know, Dennis, do you want to comment on that? What do you think of that? Have you taken any steps?
Yeah, maybe I'd start with Brian's comment as well. I think there's what is the cost of healthcare and what are hospital costs? And I think those are two different things. So there's a lot of data that shows for Hoosiers, the cost of an insurance policy for an individual or a family is right about the average in the country. So you have a group that feels like hospitals are a specific target. I think we've said we are trying to address the cost of hospitals, but in the absence of dealing with the costs of drugs, the costs of supplies, actually the utilization of care, how often are people getting care? And a big issue in Indiana is a very poor public health system has led to utilization increases. So we rank 48th in the country in terms of public health spending. And that means there are issues with smoking, obesity, infant mortality, all things that in other states, those public health infrastructures deal with. And so again, I disagree with the baseline premise that costs of healthcare in Indiana are higher than the rest of the country. It's just not true. Are hospital prices different? Yes, but that same author doesn't choose to say that the reimbursement for physicians in this state are actually some of the lowest in the country, because that's not a convenient talking point for legislatures. And so I think it's a very myopic view. We as IU Health have said we're going to change our prices. We have an insurance plan. We offer insurance plans that are less than the national average for insurance. And as Brian said, I think the other part is this comes down to access, that whatever the cost of healthcare is, whether you're high, low, or in between in the country, people need to be able to get access. And maybe the only thing I would add to Brian's comments are all of our physicians are paid the same, regardless whether you see somebody who has Anthem insurance or has no insurance. And we think that ability to say any payer gets the same access level here is critically important. So I think some of the incentives in the system matter.
Thank you so much for that response. We're running very low on time, and so we want to end in about the next 10 minutes. And so, but I wanted to ask, a couple of speed questions really quickly. So I want, some of the things that you all brought up earlier during the night that I wanted to come back to and just ask so that we can kind of talk about some of these things. One of the things that you all, that both Dr. Harris and Dennis, you talked about is about raising the wage to $18 an hour. So that would be a living wage for your employees, right? That's correct. And so that's the goal for your whole system. Is that the case for Brian for community health and Dr. Callahan for Franciscan? I just want to kind of put that out there for the whole community to hear that that's the goal for all of these systems, or when is that the goal for your system?
Two things I would say. We have raised our minimum wage twice in the past 18 months. We have the same goals that Dennis and Lisa have talked about, but at the same time, we've also raised the wage for healthcare workers many times. Okay. And that's the other thing I'll say, you get in the cost. Okay, there's been a lot of cost that we've taken on as a system that would tell you that we're just like my peers. We're here to treat patients. We don't make these decisions based upon whether it's financial return or not. We've got an obligation to do that. And that's what we've been trying to do in a number of ways, and individually and collectively. So yes, we will continue to increase our wages.
Awesome. And Jim? Or
yeah, I would say similarly, we raised our starting minimum wage to $15 an hour. We have a track to get to 18 over time. And as Brian says, we have all spent tens of millions of dollars this year in increased wages for healthcare workers of all types, because there's such a shortage of workers, and they're sought by so many entities, including those who would employ them for short periods in a travel, so-called travel setting. So the investment in our healthcare wages has been very significant this year.
Also, I wanted to just a quick round. I wanted to get, just so we can get to the last comments. Dennis, you talked about a socially vulnerable data index, right? That you all are collecting from your populations. I think Dr. Harris, you talked about identifying all Black women as high risk as they come into, so I wanted to know, though, are some of these practices that you all are innovating in your systems, are you sharing them with the other systems, and are the other systems adopting them, right? Because if this is a good practice, and I guess we're in the process of collecting data on it, is the goal to kind of share that with community and with Franciscan, and that they would also begin to have those same practices? Is that the goal? I just kind of wanted to have a sense of how you all are working together in this process of building best practices to respond to social inequity and racial disparity.
Yeah, I think, Joseph, I would say yes. I think the one impediment to that is we don't all use the same electronic health record.
Okay.
And so some of it is driven because it's embedded in that record. But I don't feel like that's a proprietary thing. I'm happy to say, here's how we did it, and let somebody figure out how to get it to work in their electronic record. But I do think these things should be shared.
Okay, so we are going to share. Brian, go ahead.
Hey, Joseph, I would just also say, when you look at people within Central Indiana, they come to all of our systems.
No, yep.
And so that's where, and I agree, there's some system things we have to get through, but by and large, through knowing each other, through working through places like the Indiana Hospital Association, the Indiana Health Information Exchange, and other collaboratives, we work for the common good. And that's what we try to do. I'm not saying we're not perfect. I'm saying we're not perfect. However, at the same time, we have always been willing to share, and that's what makes this such a wonderful place to live and work.
All right, Lisa.
Thank you. I'm glad you brought up the issue with maternal mortality, because I was thinking when we were talking about data that while we are all working to make sure that we are getting the correct assignment of individuals to various racial and ethnic groups, so that we can look at our own data critically and report it by race and ethnicity, we are not waiting for that. So this is I don't want people to think that it's going to be months before we're actually acting on some of this. And I think the example of the maternal mortality is one where we all look to the literature. So there is literature out there that has been collected in large quantities, where we can say, okay, we know that there is an increased risk of mortality in Black women. And so we don't have to wait until we prove that the same is true here. These are peer-reviewed studies, they're published. And so that is why we decided to consider all of our Black mothers to be as high risk and invest the resources in prenatal care and the special care that goes along with for high risk pregnancies.
And is that a practice that the other systems are considering or already do? I think that and this is not about comparison, but this is just about saying how we are trying to move forward and respond to some of the issues that are at play. Go ahead, Lisa or Dr.
Well, I want to point. Well, I'll let, because I'm not sure what everybody else is doing in that regard. I do want to point to something that I think we don't want to be lost, that the experience of individuals in our urban setting here in Indianapolis with the pandemic was vastly better than what played out in urban communities across the country. We actually have data. We've published the experience within Eskenazi by race, and we have demonstrated extraordinary outcomes. That is true across our community, and that was in large part because of the way all of the systems collaborated weekly in real time. Our clinical leaders, our chief medical officers, our chief nursing officers were on the phone sometimes every day, comparing what we were learning about the effective treatment. It all seems kind of straightforward now. It was not straightforward in the beginning, and we were learning by day. Our critical care physicians were reading all day and then coming in and applying what they were learning the very next day. It was extraordinary. And that was playing out across all the health systems. Everyone was working together, sharing what we were learning in real time to get outcomes in our community that were much better than what played out across the rest of the country. Mm-hmm. And we worked hard to get that in publication. I want to shout out some our Joe Smith and multiple others who contributed to a paper that while they were busy caring for all these, one surge after another and, working 36 hours and beyond straight, they also got a paper out to describe this because that informs the care more globally. So again, I think we have a very powerful spirit of collaboration here, and it played out to good advantage, I think, in the experience of the pandemic.
Joseph, two quick things. We do things like share critical medicines across the health systems when the height of the pandemic was going on. And this past fall, in the middle of the pandemic, we had 7,000 Afghan refugees moved to an area near Columbus, and we collaborated to care for that population as well.
Yeah. No, I mean, and the reason that the reason that I'm pressing on these questions is that, and I want to move to our final phase of tonight, is that the three issues that the NAACP and the recorder kind of, brought up as we met last year and as we've talked throughout the course of the year were diabetes and primary health care. They talked about mental health and mental health awareness and support. And they also talked about maternal and infant mortality. And, one of the reasons that I was asking that final question was just to say, like, if that is an intervention that can be done, or the research suggests that it could be done, how are we moving each other as a collective body to do that? So I want to move to our last question, though, and that is for you all. And I'm gonna give you about a minute each. I know that's not a lot of time, but we're running out of time, and I really apologize. To talk about what are your main priority for the next 6 months. Our hope is that you would tell us your main priority for the next 6 months or so, average, and agree to meet back with us in about 6 months, right? To talk about where we've gotten, where we can hold you accountable, and how we can move forward. Someone in the question and answer, and I just want to throw this out there, also is suggesting that you all should meet and maybe report back to the Indianapolis City County Council, because that was one of the initial bodies that you were responding to with when you made the claim that racism was a public health crisis. But we can talk about that on another day. So what I want to ask you for is, what is your priority in the next 6 months, and are you committed to coming back and reporting to this body, the NAACP and the Indianapolis Recorder, to talk about how you've responded to and collected data in relation to that priority? I'll start with Dennis.
Joseph, first, thanks for having us tonight. I'll try and answer simply. I think the most important thing for us to accomplish, and I won't say just the next 6 months, but the subsequent 6 months and the ones after that, is maintaining pace of improvement. Mm-hmm. That I actually am pretty proud in hearing my peers on this. All of us have made a lot of improvements over the past year. None of them are enough, but they're all in the right direction. And so for us, it's in those three main areas. How do we improve our culture so that we're more diverse, equitable, and inclusive? Mm-hmm. How do we look at institutional initiatives that make a difference in this space? So we talked a little bit about the living wage. There are lots of things we've got to unearth and deal with. And then these broader societal issues. So Dr. Tucker Edmonds, 80% that happens outside our four walls, how we do more in that space. And again, I think we're all doing it. We're doing it a bit differently, but we got to maintain the pace probably for 20 years if we really want the outcomes that we're all seeking. This is not a 2, 3, 4 year deal. This is going to take us a while.
Thank you so much, Dennis. Let's move to Lisa.
Well, thank you. Dennis made me think of something that I think that he said early on about we've learned how quickly we can move. And as I reflected on our work at Eskenazi Health over the past years, I prepare to present to our various audiences and constituents. I talked first about how much, that we achieved in spite of the pandemic. And then I started to think about, it's almost because of the pandemic that we had to focus, and there were so many, there was just a sense of real urgency. The pandemic brought to light why this work is so important, because it made everything worse for the very individuals we're working, whose lives we're working to improve. And our culture, we are hopeful, we're resilient, we're going to continue to build that culture of inclusion. We demonstrated the importance of this culture, I think, as we worked across all of our systems and with our partners in the community as we face down the pandemic together. We also uncovered the ravages of racism and discrimination and limited opportunity. And we see, I've said this several times, but what we're most struck by is the record numbers of patients we're seeing, both on the inpatient side and across all of our outpatient settings. And so we really have to figure out how we are going to continue to be here as that safety net, responsible to those residents of our community. So I think we need to grow our workforce. We need to grow our facilities. We're doing these things. We have to keep at it. And we have to become more efficient in caring for larger numbers of patients. And I reported on some of our progress in these areas. I will look forward to being able to share more progress over the coming months. But we also need to slow the growth of people in need of our services. And if people are falling in the river because the bridge has collapsed, the long-term answer is not to get better at pulling people out of the river. We need to fix the bridge. And so that is, gets back to that investment in the health of our community and going outside our walls upstream with efforts at prevention. And this is what we're all talking about with the social determinants of health, racism being chief among them. So we're going to continue to offer the opportunity directly through employment in our health system or indirectly by helping people stay healthy. And so we're going to grow our partnerships in social determinants. We we're going to be creating health equity zones. You're going to hear a lot more about that in the next several months from us around several of our health centers, where we are deliberately partnering with individuals within the community to address the needs that are particular to that community that are standing in the way of the opportunity of good health that we want for all those for whom we care.
Thank you, Dr. Harris. Dr. Callahan, Jim.
Yeah, thank you, Joseph. Want to thank you again for hosting us and for adding us to the group. We've been learning from the group and have learned more tonight. I think that we'll work on several things. We'll continue to educate our workforce on equity issues. We will develop that Health Equity Council that I mentioned. We'll certainly be working in prevention, as Dr. Harris said, to do things ranging from working with communities to avoid adverse childhood events to the diabetes focus we've had. And finally, Dennis oriented us to the presence of the National Association of Healthcare Executives in Indiana. That's a leading organization for Black healthcare leaders. And so we will be in connection with them on this journey as well. So thanks.
All right. And then finally, Brian.
Joseph, it's been a pleasure to be here again this evening. I'll be brief and just saying that I am confident by what I've tried to share, from the highest part of our organization to the front line, to every person who walks in as a patient or the caregiver of a patient, that this is now embedded in our organization. And that's what I think is critical, so that we've got plans in place, we've got dashboards, we have goals, we have ways to reassess how we get better. And I believe that our investment in infrastructure the last 18 months, I guess 20 months at this point, gives me confidence that we will continue to improve and eradicate racism in healthcare.
Thank you so much. And I'm just believing that means that all of you all are committed to be back in 6 months to report back. Yes, I just want, thumbs up from everybody. Yes, all right. I'm going to take that. I'm taking notes. And so this, we want to continue with the dashboards, and so those will be someone asking the questions when those will be available publicly, and I know that those are going to be coming out in the next 6 months. That some of those the dashboard that the other Dr. Tucker Edmonds presented on was talking about the work that's going to be happening from all 4 of your units, and so that will be available. I also know that we're going to be in conversation over these months as we begin to figure out ways to share this with the broader community, what's happening, not only in these larger chunks of time, but what also is going to happen as we move in incrementally and make some adjustments. I'm going to hand it over to my co-moderator to close this out, but thank you all for joining us.
Thank you, everyone. Such an important conversation, and thanks for taking the time. To have the 4 CEOs of the biggest hospitals in the state together in one call, it's a testament to what we're all trying to do here. Hope to see you again in a few months. We got thumbs up from Dennis, but haven't gotten some thumbs up. Yeah. Okay.
They are.
Okay. Thank you, everyone, and good night.
Thank you, everyone. Thank you, NAACP. Thank you, the recorder.